Hi everyone, welcome to the first episode of the Nephrology Teaching Rounds for rotating medical students and residents. We've put together a series of videos containing core nephrology content for your rotation to be delivered in a flipped classroom style. For those of you not familiar with the flipped classroom model, you will have an opportunity to review a core topic in nephrology prior to each week by watching a 20 to 30 minute video on your own time and at your own convenience. Near the end of the week, there will be a session to review cases around that week's topic led by one of your friendly neighborhood nephrology fellows. The cases will be available on Dropbox for you throughout the rotation, so don't worry if you're post-call or in clinic. This is all meant for your learning and as a resource. The topics that we picked to review include an approach to acute kidney injury, hematuria and proteinuria, principles of chronic kidney disease management, and lastly, an introduction to kidney transplantation. While the video content is geared more to medical students, R1 and R2 residents, the R3 residents may find more benefit from the case discussions each week. It's also a great time to introduce this terrifying creature named Jerry, the glomerulus. Jerry will be following us around these sessions and pointing out some high-yield topics. Of course, we're very interested in your feedback, specifically any topics of interest that you would like to hear about, the length as well as delivery method. Your feedback is always welcome, and you can email our program administrator who will send your comments back to us anonymously. And with that, let's get started on the topic for week 1, an approach to acute kidney injury or AKI. The objectives for this video include a brief overview on how we assess kidney function, the definition, general approach, and initial AKI management, and things not to miss when assessing a patient for an acute kidney injury. But in order to really understand an AKI, one has to first understand how we measure kidney function. This starts by looking at the 3 letters most important to a nephrologist, that's GFR. In simplistic terms, GFR is the product of the average filtration rate of each nephron multiplied by the total nephrons in both kidneys. At birth, you start off with anywhere between 800,000 to 1 million nephrons per kidney, which is quite a bit. It's also important to remember that GFR is impacted by many factors including age, sex, body size, and certain physiological states such as pregnancy. How we measure GFR, though, is a completely different story. GFR is derived from urinary clearance, which itself is calculated based on the urinary concentration of an ideal substance multiplied by the urinary flow rate divided by the plasma concentration of said ideal substance. So what exactly is an ideal substance? An ideal molecule or substance is defined by something that is freely filtered in the glomerulus and is not secreted or absorbed in the tubules of the nephron. If we were going to get very nerdy about it, we would use a molecule such as inulin to calculate a person's actual GFR. Since inulin is not endogenous to humans, patients must be given inulin, followed by precise urinary and plasma measurements, a very laborious task to give you a true GFR. This is where creatinine comes in. Creatinine, one of the end products of muscle metabolism, is released at a fixed rate and directly proportional to a patient's muscle mass. While it is freely filtered in the glomerulus, creatinine can be affected by other non-GFR determinants such as secretion and reabsorption in the tubules, as well as diet, but due to its ease and accessibility, is widely used as a surrogate to calculate GFR. So how do we get from plasma clearance to an actual GFR? There are many equations that exist that can use creatinine as well as a number of other factors such as age, sex, race, and body size to estimate a GFR. You might see this denoted as eGFR or estimated GFR. One of the earliest measures that was created by 2 Canadian physicians, Dr. Cockcroft and Dr. Galt, and it was the standard for eGFR calculations for many years. This simply used a person's age, weight, and sex, but as you can imagine had a lot of limitations. The equation now recommended by KDIGO is the CKD-EPI equation. However, none of these equations are great for estimating extremes such as bodybuilders, amputees, or extremes of age. To help drive this point home, here are 2 examples. In this first example using the CKD-EPI equation, you can see how 2 85-year-old females with different weights can have a GFR difference of 13 mils per minute with the same creatinine value. In another example, 2 65-year-old males who presented to hospital with increases in serum creatinine 50 points above their respective baselines have an estimated drop in GFR of 4 and 40 mils per minute, respectively. This highlights some of the problems with using GFR calculations in acute kidney injuries. The important takeaway from this slide is that you always need to look at the patient, especially in the context of numbers such as creatinine and GFR. So what does loss of GFR mean? In order to lose GFR, one of two things or both need to happen. The first is that you need to physically lose nephrons, and as you can see here in the first example, all of Jerry's friends are dead. The second is that each individual nephron could be working at less than its 100% effective rate. So while all of the nephrons are still functioning, there's a decrease in the single nephron GFR of the collective kidney. Even then, there are some implications on the calculation of GFR. For example, rises in the single nephron GFR can actually compensate for a loss in nephron mass. Thus, GFR may not actually decrease until a lot of nephrons are physically destroyed. This gets to the question of what is an AKI. In acute kidney injury, the patient has an abrupt and sustained decrease in their kidney function. A kidney injury typically occurs between 48 hours and 7 days from a precipitating event. There are many ways to define an AKI, and one of these definitions that I'm showing here is from the KDIGO Clinical Practice Guideline on AKIs, which defines an AKI as a serum creatinine increase by 50% within 7 days, or increase of 27 micromoles per liter within 2 days, or new onset oliguria. This definition is fairly intuitive, and usually by the time nephrology is consulted for an AKI, these criteria have been met. But as you can see, changes in serum creatinine values are not a good measure for GFR in acute settings. This is because serum creatinine lags behind following the start of an acute kidney injury, meaning the estimated GFR actually lags behind the true GFR in the patient. Thus, eGFR actually overestimates the true GFR in an acute kidney injury and conversely will underestimate the real GFR when kidney injury is resolving. With all this physiology, your head is probably hurting and you're probably wondering why we should even talk about acute kidney injuries at all. A few years ago, there are a number of studies that showed that there was a significant correlation between AKIs as well as hospital mortality and length of hospital stay. Patients with acute kidney injuries were also more likely to be discharged to another hospital or rehab center following their admission. Acute kidney injuries also cost the system a lot of money. This is data that's a bit older and from the United States, but shows that almost $9 billion a year in healthcare costs are associated to acute kidney injuries. And again, as shown in the earlier study, associated with a higher rate of morbidity or mortality, particularly exaggerated with the degree of kidney injury. Now let's get back to the meat and potatoes of this podcast, which is an approach to an AKI. This is a schema from the University of Calgary Medical Black Book. Most of you are familiar with this simple yet intuitive approach to an acute kidney injury. It divides it up into 3 categories: pre-renal, renal, and post-renal. While this is a good starting place, in reality, patients can have as many causes of a kidney injury as they well please. So just because you think that a patient has been dehydrated due to gastroenteritis, don't forget that they may have also taken a bunch of NSAIDs or maybe having a large prostate contributing to their overall presentation. But before you begin, one of the first things that you need to do is to establish whether or not a patient actually has an acute kidney injury. What I mean by that is that sometimes patients will have an elevated creatinine, but without any history or temporal relationship as to how long it has been at that level. Without this information, it is difficult to establish whether this is truly an acute kidney injury or whether this is a patient with chronic kidney disease. This is where you need to put your detective hat on and do a bit of searching. Is it possible to find out the baseline creatinine of the patient perhaps over the preceding 1, 2, or 3 year period? Or is it possible to establish the rapidity of rise in creatinine? You also need to take a very important history from the patient. And this may not necessarily be evident from asking the patient, since changes in creatinine values are typically not associated with any symptomology. This may involve going through charts, looking at records from retirement homes, or finding out any recent medications or procedures that may have involved contrast. A good history will probably show you the cause of acute kidney injury 90% of the time. But what happens if you don't have a baseline creatinine? Well, it's still important to do a thorough history and try to figure out whether or not this is acute or chronic in nature. And that's because the management of acute kidney injury as well as chronic kidney disease is very different. Things that might help you clue in that this may be more chronic in nature may be a prior ultrasound with shrunken kidneys or sometimes, quote, medical renal disease, end quote, evidence of hyperparathyroidism, or a normal cytic. Now let's get back to that history. You're in the emergency room and a patient has been referred to you for a rise in creatinine of unclear duration. Signs that may point you to think about a pre-renal cause include obvious GI losses, decreased intake, or starting a new diuretic. But states of volume overload, including congestive heart failure or liver failure, can also cause a pseudo pre-renal state, sometimes called nephrosarca or increased renal interstitial edema. Other symptoms may not be as obvious without specifically asking the patient. Gross hematuria or tea-colored urine, particularly in the context of new or worsening hypertension, may lead you to think about hemolysis or de novo glomerulonephritis. Perhaps the patient is complaining about a new malar rash or joint pain, or has new muscle aches and pains after starting a statin. Drug exposures are certainly a big cause of acute renal injury, and the most common ones include NSAIDs, antibiotics, and diuretics. Contrast, specifically arterial contrast, is commonly used in imaging studies and is a known precipitant of AKI. It's important to also do a quick social screen for risk factors that may put someone at risk for hepatitis B, hepatitis C, or HIV. This may include a history of IV drug use, or perhaps they got a new tattoo in a back alley after a drunken night on the town. On that note, it's always good to screen for constitutional symptoms such as fatigue, weight loss, and bone pain, which could be indicative of an underlying malignancy such as myeloma. Lastly, urinary symptoms such as increased frequency or a slow stream may lead you to think about a post-renal cause. Moving on to the physical exam. Not surprisingly, getting a good sense of the patient's vitals, specifically in the last several days leading up to their presentation, is very important. For example, many patients who have surgery and an acute kidney injury afterwards may have had some hypotensive events in the operating room, which you'd only find out by looking at the operative reports. It's important to do an assessment of the patient's volume status, including the JVP and signs of volume overload, or perhaps signs of dehydration. Uremia is also one of the things to look at, but maybe a bit more subtle and does involve taking some added notes on history. However, if the patient appears obtunded or confused, has asterixis or a pericardial rub, that should make you think that the patient is quite sick from a uremic standpoint. I also do a quick dermatological and MSK screen, since many autoimmune diseases can cause an AKI. Lastly, for obstructive causes, one of the easiest things to feel for is a palpable bladder or suprapubic discomfort. Some older texts have suggested doing a digital rectal exam to evaluate for prostate size, but the reality is that this is probably of low yield. The easiest way to see if someone is obstructed is to ask the nurse to do a quick post-void residual, and if there's high suspicion for this, ask for an urgent Foley to be inserted. Now you've quickly assessed the patient and taken a history. Most of the time, you might have some basic labs to start with, but if not, a CBC and electrolyte panel are a good place to start. Remember, in an acute setting, the most important electrolyte we worry about is potassium. Other electrolytes you might want to check include calcium, either ionized or corrected with an albumin, and phosphate. To check for acidosis, an arterial or venous blood gas may be helpful, but you can usually get an idea with a serum bicarbonate. Urine studies, including a urinalysis and urine protein to creatinine ratios, as well as urine electrolytes, can also help provide some diagnostic clarity. But the thing I really like to do is to take a sample and look at it under the microscope myself, because this is something you can do quickly and can provide quite a bit of information. Particularly, if you see granular CAS, this may suggest ATN, or highline CAS may suggest dehydration. Then there's always the dysmorphic red cells and red cell CAS, suggestive of a possible glomerulonephritis, or white blood cell CAS, possibly indicative of acute interstitial nephritis. There are also a lot of extra tests that could be ordered, but many of these are things that could be delayed until your initial tests are back. Due to how long these tests take to be returned, they may not be helpful in your initial management. Some can also be quite pricey, like a flow glomerulonephritis panel, especially if you're adding things like ANCA or PLA2R. Thus, these tests should only get ordered if the clinical picture is suggestive of a GN. Urine eosinophils have notoriously low sensitivity and specificity, so aren't very helpful at diagnosing acute interstitial nephritis. In the same vein, 24-hour urine collections in an acute setting usually don't add much more than a random urine PCR. Of course, there are caveats to all these suggestions, so don't take them as a rule. Most importantly, however, a renal biopsy is a fairly invasive test and is not without insignificant risk, including bleeding and infection. So it's helpful to have a nephrologist input before committing patients to a biopsy. Let's have a quick sidebar on the fractional excretion of sodium, or FeNA. This is something you may have come across to help determine what kind of AKI a patient has. Typically, a FeNA less than 1% can be indicative of a pre-renal AKI, but there are some exceptions to the rule, including liver or heart failure, or pigment or contrast nephropathy. Also, patients on diuretics can have a falsely elevated FeNA. So while FeNA in some cases can be quite helpful, can falsely mislead. For that reason, some people have looked at using the fractional excretion of urea as an alternative measure. An F-urea of less than 35% is suggestive of pre-renal AKI, much like the FeNA of less than 1%. Again, this isn't without issue though, as you can see in some small studies, while the F-urea may perform better in terms of sensitivity in patients on diuretics compared to the FeNA, it actually has a lower specificity and lower negative predictive value. Thus, much like the FeNA, the F-urea needs... Okay, so now I've rambled on for a while about taking a good history, completing a physical exam, and sending off some initial tests. But here's where things start to get interesting. The first thing to always think about is whether the patient needs urgent dialysis. In reality, it probably takes 2 to 3 hours to facilitate dialysis, so don't forget to start medical management while waiting for the dialysis machine to show up. If you're in the emergency room in the middle of the night and you're not sure if the person needs dialysis, it's not unreasonable to give nephrology a call early just to get the ball rolling, or to have a second opinion as to whether or not the dialysis team needs to be activated. Most patients with an AKI would probably benefit from a trial of fluids. Obviously, you need to take a look at the patient to make sure that they aren't grossly volume overloaded, but by and large, most patients can tolerate a gentle fluid challenge. The type of fluid you choose is really up to you. Keep in mind that lactated ringers contains 4 millimoles per liter of potassium, but compared to your total body store of 55 millimoles per kilogram body weight, this is quite small by comparison. Alternatively, normal saline may lead to generation of a hyperchloremic non-anion gap metabolic acidosis, which in critically ill patients may be associated with worse kidney outcomes. But at the end of the day, some fluid is probably better than no fluid at all, again, assuming that there's no contraindication. Remember to take a look at the patient's current and home medications and adjust them as necessary according to the GFR. Doing a quick bladder scan or inserting a Foley catheter is a quick way to get a urine sample for your investigations, but it can also solve a post-renal cause, particularly if 2 liters of urine comes out right away. Hopefully by this time, you'll have some of your initial investigations back, and the potassium, calcium, and bicarbonate aren't in red with tiny exclamation marks. But if they are, it's pretty important to correct these sooner than later. Let's take 2 minutes to talk about acute potassium management, because this is probably one of the more common things you'll deal with in an AKI. Most centers define hyperkalemia as a serum potassium of greater or equal to 5.5 milliequivalents per liter. I'll hopefully talk about potassium disorders in a later episode, but briefly, the most important thing is to be able to stabilize the myocardium, shift the potassium, and then get rid of it. In order to stabilize the myocardium, usually 1 gram of calcium gluconate IV is sufficient. 2 ways that you can shift the potassium is to use beta-2 adrenergic receptor agonists such as salbutamol, but remember that you usually have to give quite a bit of it for it to work, usually in the realm of 10 milligrams or more. Patients can also get pretty tachycardic and uncomfortable from that much salbutamol. What's more commonly used is the old dextrose and insulin combination. This usually involves giving an amp, or 50 grams of dextrose IV, followed by chasing it with 10 units of insulin R IV. Some complications that can occur with this are hypoglycemia, particularly in patients who are non-diabetic, and also not monitoring for a rebound potassium afterwards. A good shift probably only lasts between 4 to 6 hours, so not eliminating the potassium either by dialysis, the gut, or in the urine may result in that unintended rebound. To get rid of the potassium binders such as SPS or Kxalate with some lactulose is a good method, but this usually doesn't take effect for several hours. There's also a small but significant risk for adverse gastrointestinal events such as bowel ischemia or perforation. One of the things that you can do is actually to use the kidney itself. If the patient is still making urine and there are no contraindications to diuretics, a good dose of Lasix can quickly get out some of that potassium through the urinary system. Let's say the patient isn't doing very well though, and you think that the old dialysis machine is going to be needed. You may remember from medical school that the vowels A, E, I, O, and U provide an easy to remember mnemonic for urgent dialysis indications. This stands for A for acidosis, E for electrolyte disturbances, I for intoxications, O for volume overload, and U for uremia. But remember, all of these indications should be refractory to medical management before considering dialysis. For example, if a patient with type 1 diabetes presents with DKA and severe AKI due to vomiting, the first step should be to provide insulin and fluids, and similarly, patients with volume overload from severe congestive heart failure should have had a good college try of diuretics, to the point where they may become resistant. Intoxications, such as methanol and ethylene glycol, may be the exception though, as usually medical management does involve dialysis, particularly in severe overdoses. A number of medications can also be easily dialyzed, and this website listed here is a great resource for dialysis indications in these overdoses. Lastly, uremia can be quite vague and difficult to discern, particularly in patients with chronic kidney disease who are close to starting dialysis. Remember that serum urea is not directly reflective of uremia, and there are many unmeasured molecules that contribute to this syndrome of uremia. Uremic symptoms may include decreased appetite, fatigue, and generalized malaise, in addition to those listed here on this slide. Moreover, severely uremic patients may also have a pericardial rub on auscultation or be obtunded. While there's no rule for urea level, severely uremic patients are likely to have a urea well above 25 or even 30. I'd like to end off with a throwback to the schema from earlier in the talk. There are a lot of causes of AKIs, most of which we haven't touched on today. This flowchart is a good general approach and covers many of your AKI encounters that you'll see throughout your nephrology rotation. If you don't have a copy of the University of Calgary Black Book, the most recent edition can be purchased from the UFC Medical Bookstore. I hope that this first video has provided a little more clarity around how we measure kidney function and the approach to an acute kidney injury that you may see during your time with us. Remember to take a look at the cases on Dropbox, and at some point during this week, join us for a case discussion to build on the concepts covered here. Till next time,